Good afternoon, everybody. Yesterday I had taken fluid and electrolytes domain. Today's domain is hematological management. So before starting, what are the questions I'm going to cover? The important subtopics particular to these domains, I'll talk about those things first. So if I talk about hematology for the EDIC exam, for the any European exam, the ITP, TTP, DIC, okay, all these are very, very important. Coagulopathy, and from the drugs prescriptive, heparin, mechanism of action of heparin, heparin resistance, dosing of heparin, complications of heparin, and then options to give in case of heparin induced thrombocytopenia. What are the drugs you use in HIT 1 or 2, types of HIT 1 or 2, and then warfarin, mechanism of action, reversal agent, how will you reverse, at what INR you will reverse is very important. Then antiplatelets, the mechanism of action is one of the favorite topics. For consecutive 3-4 years, there was a question regarding some, like 1 year they asked about mechanism of action of aspirin. In my own session, they asked me mechanism of action of clopidogrel. Okay, so the drugs, like only 5-6 drugs are important, are there in hematology. So you should be very well through those drugs, including from the mechanism of action, their doses, their side effects, and management of those complications. Okay, and conditions like ITP, TTP, DIC I already told. So I have 20 questions and we'll start. I have some like 14 questions type A and 6 questions from type K to just cover, because in exam also you'll get some 60 to 70 questions from type A and 30-35 questions from type K. So let's start. Type A. Yeah. A 27-year-old lady presented with a sudden onset of weakness affecting her left side. Okay. There was no history of headache or head injury. She had previously been well, with the exception of she had a mild Raynaud disease. Though she had 2 previous miscarriages 4 years ago. This is very important. That's why I just highlighted it. I could not do it yesterday, but now, like, for the difficult questions, for the important points, I have just highlighted, but in exam it won't be there like that. Okay, so she had 2 previous miscarriages, but she had a successful pregnancy 6 months back, and after, like, but now, but that was complicated with the DVT. Okay, on examination, she had a left facial palsy and she had a obvious left side weakness. Her heart rate is 80, blood pressure is 150/88. Her heart sounds are normal, and there is soft systolic murmur in the pulmonary area. The chest was clear. Her labs were like hemoglobin was 11, total counts were 11,000, platelet were 1,22,000, ESL was 11. Okay, her CT brain showed right MCA territory infarct. Her echo was normal. What is the most probable cause of the stroke? You need to type the answer in a chat box. Should I go back to previous slide just to reassess the question? Okay, I can see many people are answering. D. Very good. So yeah, the answer is actually lupus anticoagulant syndrome. And why do you say that? Because she had a predisposition to arterial and venous thrombosis. Okay, so this time it is arterial, like MC territory, and she already had a venous thrombosis, like in terms of DVT. Okay, and she had a miscarriages. So, and again she had a Raynaud's mild, though it was a mild Raynaud's phenomenon associated with thrombocytopenia, all of which is a characteristic of lupus anticoagulant syndrome. The normal is echo, ruled out atrial septal defect and paradoxical embolus. Next question. What is the mechanism of action of tirofiban? Answer, please. Yes, good. Everybody knows. Okay, so you can take a screenshot of this. This one slide is enough to remember all the mechanism of action of all the antiplatelet drugs. Okay, so aspirin mechanism of action is COX inhibitor. ADP inhibitors include clopidogrel and ticagrelol, ticlopidine. Okay, PD inhibitors like a dipyridamole and sildenafil. GP2B3 inhibitors like abscisimac and tirofiban. Okay. Next question. A 48-year-old smoker presented with a right DVT affecting right calf. Apart from swollen right calf, her physical his physical examination was normal. Okay. Uh, on abdominal examination, there was no organomegaly. Okay, that is important point here. He's a smoker and there is no organomegaly. On labs, his HB was high, his PC was high. Okay, platelets were normal, WBC was normal. Okay, the blood film was also normal. What is the hematological abnormality? You can assess by seeing the HB and PCV. Okay. Good. I think I have made it a bit easy by highlighting the points because everybody is getting it right. Yes, no. Hamid has answered C. No, it's actually it's secondary polycythemia. See, he's hemodynamically stable, no organomegaly, and he has a predisposing risk factor that is he is a smoker. So it's a polycythemia for sure. So you have to differentiate between pseudopolycythemia, primary polycythemia, and secondary polycythemia. How will you differentiate? The answer is secondary polycythemia. How will you differentiate between three? So in pseudopolycythemia, the HB and PCB both are raised, but there will be hemoconcentration. Okay, maybe the dehydrations or because of the excessive use of diuretics. In primary polycythemia, along with the raised HB and PCB, there will be rise in a WBCs as well, and there will be splenomegaly. But in this case, there was no organomegaly and WBCs were normal. So that's why it is a secondary polycythemia. Okay. And this secondary polycythemia happens because of the excessive circulating level of erythropoietin, and it usually happens in those predisposing factors like those living in high altitude, COPD patients or cyanotic heart disease patients. Okay. In this case, there is no organomegaly and WBC platelets will be normal. Next question. A 35-year-old lady presented with epileptic seizure 5 days after having cesarean section. There was no previous history of seizure. She had throughout her pregnancy. She was well, and she had 2 normal pregnancies without any complications previously. Okay. On examination, heart rate was 90, and which was regular. Her temperature was high, 100.2 degree Fahrenheit. Her blood pressure was high, 180 by 100, and her GCS was 13 by 15. There is no evidence of focal neurological deficits. Her labs were like HB10, WBC 11, platelets 45,000, sodium was 137, potassium 4.6, urea 10, creatinine 145 millimoles per liter. Bilirubin, LFT was like apart from LDH, others were acceptable. Okay. And there was protein on urine routine examination. What is the best management step? First, tell me the diagnosis here. Okay. Think about the diagnosis. Huh?
TTP, sir.
Very good, TTP. So see why when you have this kind of straightforward question before going to the options, think about what is the best management. So tell me before giving you options, tell me you got the diagnosis right. Tell me the best management strategy.
Plasmapheresis, sir.
Correct. Okay, so think about the answer before actually going to the options. So the probability of getting confused among the options will be less, and you'll get the correct answer. Because see, like like Ashutosh sir was talking about surveying sepsis guideline. It was straightforward questions, but without actually thinking the answer in, if you go to the options are closely related. So because of the time constraint and because of the exam stress, you may get confused between the option. In hurry you may click the wrong option. So if you are very sure about the topic, if you are sure about the answer, please thought about the answer before actually going to the options. That always helps, and the probability of getting confused among the answers will be less. So here the answer is yes, plasma exchange with the FFP. Okay. So the pentad, what did you see? Why did you diagnose the TTP here? Okay, she had a AKI, she had a hemolytic anemia because LDH was high. There was thrombocytopenia, and she had a seizure. How will you differentiate between HES and TTP?
Neurology. HUS predominantly have a renal involvement, sir.
Yes, correct. Okay. So this patient is a postpartum presented with epileptic seizure. So neurological involvement is taken over. So between HAS and TTP, the TTP is the preferred thing, and the two conditions are part of the same disorder. Okay. But the classical TTP has characterized by neurological manifestations more commonly than the HAS, and the HAS, the renal involvement will be relatively higher. Okay, the neurological features can be headache, seizure, coma. Okay, but there will be no focalizing signs. Okay, the treatment of TTP includes plasma exchange with a FFP. Okay, next question. What is a specific reversal agent for the dabigatran? Theoretical question, straightforward. Yeah. Yes. Answer is B. Idurisuva. So dabigatran uh, is a direct thrombin inhibitor, and the reversal specific reversal agent for that is the only oral Novax which we got a reversal agent, that is a ridarucizumab for the dabigatran. So many people preferring dabigatran over other Novax. So ridarucizumab, you should know, it's a monoclonal antibody. Okay, it is indicated patients who have risk of high bleeding for the reversal, or they are posted for any surgery or any high risk procedures. Okay. Next question. A 70-year-old lady was investigated for lethargy. On examination, she appeared slightly pale, but all other aspects of her physical examination was normal. Her labs were like hemoglobin was 6, WBC was 3,000, platelet was 1,15,000. Her MC was high, 180. Ferritin was on a high side. Uh, bilirubin was 35, LDH was high, 1,500. ALP was slightly raised, albumin was normal. What is the diagnosis? Everybody's getting it right. Yeah, so here the highlighting point was there is a pancytopenia and with a high MCV, so megaloblastic. So there is some problem related to the maturation of the bone marrow cells. Okay, so it's like pernicious anemia, could be the vitamin B12 deficiency or folic acid deficiency. So pernicious anemia is the right answer. Okay, so this patient lethargy, mildly red MCV with a pancytopenia. The best possible answer is a pernicious anemia. Though the raised MCV is due to large immature cells secondary to immature nuclear development. Okay, so he indeed more than 115 of MCV, possibility of DNA mature, the abnormality of DNA maturation of the cells. Okay, so the DDs for that is like B12 deficiency, folate deficiency, or what are the drugs affect this DNA maturation? Can anybody tell me the example?
Methotrexate.
Yes, good. Yeah. So the raised ferritin does raises other disease, but this is because of the reduced synthesis and hemolysis of the immature cells. Okay, aplastic anemia would explain your pancytopenia and raised ferritin, but it won't justify the raised MCV. So the pernicious anemia is the right answer.